Thanks, Billy. One of the toughest conversations I think to have are the myelopathy patient with mild clumsiness, and it's always an older patient and just thought it was her arthritis or his arthritis in the hands, with a Hoffman's and no pain, and they have severe compression core signal change. That's a tough conversation to have if you're going to put them through a big posterior cervical surgery, knowing the complications that can occur. Is that something you've had trouble with, or do you think they're just scared enough from what the imaging looks like to jump right into surgery? Because that takes a lot of counseling. You're taking someone with zero pain and giving them pain sometimes. Billy, yeah.
So yeah, I mean, ultimately at the end of the day, the timing is critical, right? So this is, hopefully the crux of the talk. The issue is that to wait, there's consequences as well. So we talking about risk stratifications earlier on. I've had a couple of people that were indigent who smoked, who required a posterior cervical pressure perfusion due to their inherent neck pain, their preserved low doses, and their multi-level disease. I've made weight, and I've seen it get worse. So I would say nothing inherently is benign. In terms of cervical laminoplasty, I mean, that really winds up being my go-to if they don't have a lot of neck pain and they cervical basis. But even that, right? I mean, maybe people are slicker than I am in terms of getting their patients out. But a cervical laminoplasty is a procedure where the patient, my hand, went in the hospital for 2 days, maybe sometimes, due to their paraspinal neck spasm. And it's not something that's without consequence. I mean, the posterior laminoplasty procedure, well, you're good numbers about it. You still have patients with hematomas, you still have patients with wound infection. So it's not benign. So you're right, it is a difficult conversation. So, if a patient elects to wait, I encourage them to wait. But the downside of it is just that. I mean, if you wait until you're so profound with myelopathy, and people expect more, right? The people that I take care of that are a bit elderly, that number changes every year as I get older. People expect that. You get this sense like they expect. I had a guy who I operated on who was, with his retirement job, he was removing and work with small items. And his demands with regards to his myelopathy are different than somebody who, sits on a rocking chair and really just wants to be able to get up and have some basic activities to be able to live in. So it is a long conversation.
Yep.
What about, I'm seeing kind of a range in our community of these younger patients, say in their 40s, congenital cervical stenosis, multi-level disc bulges, basically a tight canal from C2 or C3 down to C7, but 2 levels, say 5, 6, 6, 7, definitely have core compression. And they have, they have a significant amount of neck pain, and a lot of those patients have occipital headaches and have some ridiculous complaints. And people are doing cervical disc arthroplasties on those. And to me, that especially that congenital stenosis is a disease of motion, and you're not taking care of. You're still getting buckled in the ligament and flavor. You still have a congenitally narrow canal. Has there been much studies on that? I mean, it's easy for the large disc herniation that just compresses the core, but those multi-level stenosis, the congenital deformity, not deformity, congenital stenosis. Any thought process on that? Yeah. No, arthroplasty.
The arthroplasty side, I mean, the IDE studies that have myelopathy that were included in them show that disc arthroplasty is effective, but they were multiple disease parts.
Right.
One or two of them solid. So, and they, in terms of saying whether they were congenital or whether they were, due to spondylosis, and I can't tell you. At least the ones that I've seen, spondylosis, it's not a solid.
Yeah, I don't think those studies distinguished between the two, but I agree with you. I think that's a laminoplasty in my hands in a young patient.
That patient you just described that has very little symptoms.
Yep.
And you don't want to do a laminoplasty because they don't have much, debilitating neck pain.
Oh, yeah.
They have neck pains. Basically, the only complaint, and then they go to someone who sells them on this 2-level disc arthroplasty.
Oh, yeah.
Is that a realistic option? And I'm not sure it's the right operation.
Yeah, I would agree.
In the case that you just mentioned, with this patient symptomatic, it's not he has a severe stenosis, he has some myelopathic finding. To me, this is an easy decision, even if it is compressed.
I don't think the question was that whether or not the person has surgery. I think it's sometimes pain is such an easy motivator for a patient to jump into surgery. They're begging you sometimes. But when they have these subtle symptoms of clumsiness that has been developing over a year and a half and no pain, they sometimes, especially where I'm in DC, a city full of self-declared VIPs, they demand perfect results and are shocked that you're telling them that you have to have an operation. It's a very difficult conversation that requires a lot of counseling because there's a lot of downside, that can occur. And I just think it's a much harder conversation when they don't have pain motivating them into surgery. But let's get going so we don't have to miss any skiing today. So I'm going to talk about timing of surgery with myelopathy, and here are my disclosures. So we're going to talk about the natural history of cervical stenosis myelopathy and see if we can evaluate any evidence that may or may not even exist, and then determine, hopefully, if our preconceived biases are actually valid. And what are those biases? What do we think? What do we tell patients? Surgery will prevent you from getting worse, but may not make you better. I say that 20 times a day. If you don't have surgery, you're going to get worse. You could be paralyzed if you fall or in a minor car accident. I think a lot of us have said that in some form or believe that in some form. And is that in fact true? So we understand the rationale for why we do recommend surgical treatment. We want to prevent that catastrophic event. We want to preserve as much of the neural function as we can. We want to prevent irreversible damage. So early intervention is generally the normal tendency for most of us to recommend. And we understand that because there can be a very limited capability of repair or regeneration, especially if we see a lot of core signal change or if the symptoms have been present for years. So we have a good foundation for why we recommend surgery just rationally, I think. But where do we get this information that sort of sends us there? And Billy touched on this article, but a couple of articles. But one of the ones that we really started to look at was this Clarke and Robinson in 1956. And they did this retrospective review, and they looked at 120 patients, and 26 of those patients were untreated, and 94 of those patients were treated either with non-operative bed rest traction, and then some actually went on to surgery. And this is where the first discussion of stepwise episodic progression occurred. And they noted that about 75% of patients had that sort of stepwise plateau and then progression. And 2/3 of those deteriorated, and about 1/3 of those remained unchanged. About 20% had a slow, steady progression just on a downhill line. And about 5% had a rapid onset, and then they would go into a plateau phase. Then they looked at their results. They found that people with medical treatment, this is just bed rest collar traction, 50% of those improved, but those were mostly mechanical pain symptoms, radicular symptoms. Not very many of them improved in any motor strength, and about 50% remained exactly the same. And they found that the motor symptoms were more persistent for those patients than the sensory symptoms, and they did not see anybody spontaneously improve back to normal. So what about the surgical results? If this was the statistics I would have, I don't know what, I'd be a hand surgeon tomorrow. I mean, this is 10% died of patients treated, 5% immediately worse, 6% delayed worse, and only, 6 people, and 13 people improved slightly. So pretty horrible results, but despite all that, their conclusions were ultimate prognosis is poor, progression in most cases was very slow. Treatment with cervical support, non-operative care could be advised, but if there's any deterioration, you want to jump into surgery before the patient is severely disabled, or in their case, before they severely disabled the patient. Lees and Turner, 1963, they looked at natural history. They looked at a retrospective observational study, and they had 2 groups. And they had a myelopathic group, which was 34 patients that they followed for 5 years, some up to 30, and then a non-myelopathic. These are radicular symptoms, axial neck pains, and they had about 50 patients. And they found that no mildly disabled patient got worse. And all patients in what they classified as moderately disabled remained that way. It was only the severe disabled patients that had progression. Some of them actually improved. And what they considered severely disabled were those with objective myelopathic findings. So an asymptomatic patient with the Babinski's, they put into the severely disabled category. So their conclusion was myelopathy hardly ever developed in patients who did not show it when they first came into the office. Long periods of non-progressive disability is the rule. And the results suggest that a very conservative approach should be the rule here. So is there any evidence that actually supports surgical treatment? We've been quoting those kinds of articles for years. I've been told about that from fellowship on, without really understanding what they were looking at or what number of patients they were actually evaluating. So in 2002, there was a Cochrane review on this, and they found only 2 randomized control studies that involved a total of 130 patients. And they basically concluded that the widespread belief that overt myelopathy will eventually develop in patients with spondylosis and radicular symptoms is not based on any good evidence. And they found that the small randomized trial do not provide reliable evidence on the effects of surgery. So we're having trouble, even into the 2000s, of actually having research support what we all believe and actually what we all anecdotally see in our own practice. Let's get past 2002. In 2008, Bednarik looked at 200 patients, and these patients presented with axial pain or radiculopathy, but no symptoms of actually myelopathy. But on their MRI, they had spinal cord compression. And they followed these patients for more than 2 years, and they found about 23% actually developed myelopathic features. So pre-existing cervical stenosis, no myelopathic symptoms on presentation. About 23% actually developed myelopathy. And they found the best predictor for that, and this was alluded to in the last talk, was the presence of radiculopathy in addition to an MRI finding of cervical stenosis. And they found that those patients developed myelopathy in most cases in less than 12 months. In the patients that developed myelopathy later on, those were patients that had MRI cord signal changes at that initial evaluation. So again, these patients came in with neck pain or radicular symptoms, no objective or subjective myelopathic symptoms, and about 23% of those patients actually did progress. So maybe we're seeing some evidence now that this is something that can get worse. Murphy did a systematic review of spinal cord injury in the setting of patients with spinal stenosis, and they trying to determine if there was a risk-benefit of prophylactic surgery, and they found that they could not conclude that there was any significant risk to an increased spinal cord injury from even minor trauma. And they did a systematic review, and that's just based on what was out in the literature. And then John Rhee, one of my mentors, did a good systematic review in 2017 where he looked at non-operative versus operative, and basically included or researched 225 citations, and they found that non-operative treatment for the Japanese Orthopaedic Association score of over 13 for single-level myelopathy resulted in similar outcomes to surgery. And they found that these patients should be monitored closely but not operated on, whereas those with moderate to severe should have surgery. One interesting thing that they found, but didn't have enough good research to make a strong conclusion on, as opposed to the previous systematic review, was that non-operative management of people who, with myelopathy had higher rates of subsequent hospitalization for spinal cord injury. So that's something that they concluded needs a little bit more diving into. Just so you guys know what the Japanese the JOA score is, if you guys use it at all or not, it just is a way for us to classify patients into mild, moderate, or severe. And I think these classifications just offer us maybe some homogeneous results as far as putting patients together to determine if they're actually benefiting from what we do or not. So what do we do with all this? Are there any predictors for progression? Well, a good summary article that looked at the research that has been out there about this basically concluded that these are the most common predictors that have literature support. Neurologic progression, that's an easy one. Symptoms greater than 6 months, so myelopathic symptoms greater than 6 months. The presence of radiculopathy seems to be all over the literature. You have findings on EMG or MEP if physicians are sending their patients for that, for cord dysfunction. T2 MRI findings, signal change, and then the compression ratio in transverse areas. If they found that these were present, the prediction for progression was high. So is there any consensus? So take all that literature, natural history, when do we operate on these patients? How do we classify these patients into groups so that we can watch them or operate on them quickly? Well, we've tried to put that together, and Phalanx did that with a practice guideline, and this was done by the AO Spine and the CSRS. They developed a guideline development group specifically for this, and they did a systematic review to help support these conclusions. And they divided these people into 5 different populations. The severe myelopath, which had the JOA of 0 to 11, the moderate, which is 12 to 14, and then the mild, which was 15 to 17. And then they had an asymptomatic stenosis with no radiculopathy, and then an asymptomatic with radiculopathy. The easy one I think we all can agree on was with severe, based on the JOA score, surgery was recommended. And this was strongly recommended by the guideline and with some moderate quality of evidence out in the literature for that. So if that patient walks into your door, that's someone that you're going to recommend surgery sooner than later. For moderate, they also recommend surgery, and this was also based on a strong recommendation in the literature based on moderate quality of evidence. So those patients, if you're going to use that determination, I think is an easy discussion for surgery. The mild, the recommendation was actually non-operative care. So this is that patient that comes in with mild dysfunction, though they may be present, and they have cord signal, even cord signal change. Their recommendation is a supervised trial of structured rehab and operative intervention only if there is neurologic deterioration. And this is based on weak recommendation with weak, low-quality evidence. That this isn't really supported out in the literature. So this is one of those things that just is left to a surgeon's gestalt. At some point, when do you see a patient and feel like this is something that they're going to be at high risk for progression for?
But isn't that simply saying if they go from mild to moderate?
Correct. Yeah. But this is sort of from a timing perspective. When they walk into your door, you're seeing them for the first time. How do you determine surgical intervention? Asymptomatic, no radiculopathy. This is initially a non-surgical observation, but you have to have a good conversation of counseling of patients because that is a predictor for progression. And this is something that there's some very good evidence to support that. And so this patient should be counseled. You should not operate on this patient on initial evaluation, but they are at potential risk for progression. Also, weak recommendation and actually no identified evidence based on clinical expert opinion as far as going down a non-operative course. And then the asymptomatic with radiculopathy, patients are at higher risk. So this is up to the individual surgeon. If you have a patient who's very, has a lot of significant radiculitis, a lot of pain, weakness, obviously that's a patient you're going to be taking to surgery potentially anyway. But in this category, if you're going to manage their radiculopathy non-operatively, you need to have close supervision. So what can we conclude? There's basically insufficient data for treatment standards, but there is some data for treatment guidelines. And we really have no good data for the role of prophylactic surgery in asymptomatic patients. So in those patients, I think a non-operative course of treatment is, or management with close observation is reasonable. And we really have a good consensus, I think, on severe and moderate myelopathy, but mild and asymptomatic should be at least observed. And you need to counsel the patients on the risk of progression or potentially spinal cord injury, though this is not based on a lot of good data in the literature. So we should not really be scaring our patients into surgery that they're going to slip down the stairs and become paralyzed because that's just not supported, though the patient should be counseled. Okay, thank you.